Ladies and gentlemen, thank you for joining the Improve Heart Failure, Self-Care, and Reduce Readmissions Using Data to Understand the Problem conference call. Your host for today is Barbara Link. You may now begin.
Thank you so much. Good afternoon and good morning to some. Welcome to today's webinar. This is the Improve Heart Failure, Self-Care, and Reduce Readmissions Using Data to Understand the Problem, presented by the Lake Superior Quality Innovation Network. The Lake Superior QUIN is comprised of three organizations, MPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. Today's webinar slides will be available on our Lake Superior QUIN YouTube page within the next week. Because Medistar is providing continuing education credits for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speaker has reported no conflicts of interest and there are no planner conflicts of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive. We encourage everyone to complete the evaluation to provide feedback on the session. Now I'd like to introduce you to our speaker today. Karen Bush is a hardworking professional leader with over 25 years of experience in healthcare. She began her career as an ICU and ER nurse in both urban and rural settings, and in 2003 she earned a master's in nursing from Saginaw Valley State University and became a board-certified family practice nurse practitioner. She's practiced as a primary care provider in the outpatient and inpatient arena with experience in hospice, hospital medicine, and long-term care. She has recently worked for Covenant Healthcare, where her primary responsibility was to drive the development and implementation of transitions of care initiatives within the hospital, in addition to creating and functioning in the role of transition coach. She has achieved a national certification in readmission prevention. Currently, she is employed with Health Trust as a Director of Clinical Data Solutions, where she assists hospitals to utilize data to identify opportunities to improve patient care. As the president of Self-Care Solutions, LLC, Karen continues to work to assist healthcare providers reach out to their patients with meaningful information and tools for self-management. At this time, I would like to turn it over to Karen. Welcome, Karen.
Good afternoon or good morning in some areas, I understand. It's great to be here. I appreciate everyone taking the time to get on the call. As stated previously, in my previous position, I worked in the area of care transition, and initially I worked with primarily heart failure patients, and then eventually we extended to all cardiac patients. So I have had some significant work in that area, and in my current role with Health Trust, I assist hospitals with obtaining and analyzing data to positively impact the quality of care surrounding their cardiac patients in the hospital. So as we know, data is used in a multitude of ways in today's world, and data analytics is a field that is rapidly growing. Those people that can look at data, understand it, and then use it to impact change can really have a great advantage in many areas of healthcare and business. Now, many of you have heard the story of the young teenager whose father came into the local pharmacy and he was really angry because his daughter was receiving coupons for baby items. And the manager was very apologetic about the error and advised that he would ensure these coupons stopped. Well, a few weeks after that, the father returned and apologized to the manager because, in fact, his daughter was pregnant. Now, how did the pharmacy know this daughter was pregnant before the father or her doctor? Well, she went into the pharmacy and bought a pregnancy test and some vitamins using a card. So the data around us is used in a multitude of ways. We all know from Amazon, from Google, they're sending us constant messages about things that they feel we should be buying. So it is an arena that can be very powerful, but the key is to understand how to harness the data to improve the care that you provide your patients. So in this presentation, I'm going to walk you through an example of how we use data to really work on our our initiative to improve heart failure care and transitions and therefore reduce readmissions in our hospital. And then I'm also going to talk a little bit about a common cause analysis and how we use that type of analysis to improve our understanding of readmissions in the AMI population, which can also be translated over to the heart failure area as well. So we're going to go ahead and get started. I do have to say that I have an affiliation with Health Trust and Self-Care Solutions. I also want to let you know there is CME and CNE credit or attendance certificate, full session attendance, if you complete the evaluation online afterwards. I just want to make sure you know that. I'm a director for Clinical Data Solutions Health Trust. I'm president of Self-Care Solutions, LLC. I currently own all copyright, patents, and trademarks related to the project that I'm going to be discussing. So the first key when you're talking about data is using data to get buy-in. When you start working on care transitions, you have to get those key stakeholders around the table. And typically when you're working in care transitions, you have a lot of varying backgrounds when you're dealing with care transitions. You have inpatient, outpatient, you have physicians, you have nurses, you have nursing leaders. And so it's important to understand getting the accurate data, but also knowing your audience and how they'll respond to that data rather than just giving them basic data. So first of all, when we talk about care transitions, some of the data that you talk about is the global perspective. And for any of you who have worked in care transitions for any amount of time, you will have seen this data because it appears in almost every piece of literature and presentation. The hospitals account for nearly a third of the total $2 trillion spent on healthcare in the United States. According to analysis conducted by MedPAC, up to 76% of rehospitalizations occur within 30 days in the Medicare population, and 76 are potentially avoidable. And it's estimated that 20% of Medicare hospitalizations are rehospitalizations. So it's no wonder that Medicare is looking at this, and this is the global perspective of why we really need to work on safe transitions for our patients. So that will connect with some people, but it's also important to provide the patient perspective. Particularly your frontline caregivers are going to connect with this if they've done any work with patients and seen readmissions. Readmissions do impact the patient's health and well-being. Physically, it's draining. Emotionally, it's draining when they have to come back to the hospital. And it's also financially draining. And not only that, but it does impact family and caregivers as well, physically, emotionally, and financially. And now with all of the data that's being publicly reported, it impacts how people view the care provided at your hospital. So it's really important when you have people in a room start off your initiative that they understand and connect with why do we need to do this. And then finally, if you have any leaders in the room, everyone should care about the financial impact that this is having on your hospital, but particularly your nursing leaders and your hospital leaders are going to connect with some of the financial implications of readmission. So when you're trying to gain support, make sure you remind them, this is why we need to be looking at this. And, of course, there are a myriad of them. The hospital readmission reduction program recently bundled payments where you're on the hook for care of this patient for 90 days post-discharge. And it started with joint replacements. Now we have the SHIP. We have the cardiac bundle that includes AMI and isolated CABG. So all of those programs, they're looking at cost of care. They're looking at quality in the form of excess hospital days post-discharge. And it also affects your outpatient providers in the form of MACRA. They're looking at their MIPS reporting, some of the alternative payment models. And if you think it's stopping at Medicare, it's not, because your private payer sources are also looking at this. They have an emphasis on quality. They look at total spending per beneficiary. And a lot of your centers for excellence, readmissions is one of the indicators. So those are some of the key areas that if you're trying to get buy-in from a group of people, make sure you're communicating the need. And then drive it home by showing some of the numbers that back it up. So rather than just saying what your readmission rate is, give them a benchmark. So for our hospital, for instance, according to the most recently published hospital compare data, the readmission rate national was 23%. At the time when I pulled that data, using the same criteria, we were at 26.6%. That's a much more effective way of communicating the data than just to say, oh, our readmission rate is 26.6%. Look at some other factors to your state, some of the financial impact. There's a lot of organizations out there right now that can provide you with data. We do a lot of that right now in my role, and we look at, what are the costs of these complications? And again, make sure you're benchmarking the data against either a group or state level. And some of your benchmarking can occur if you're participating in a collaborative. That can help because you can get yourself compared to the other members of the collaborative. Or if you're working with a company that does data analysis, they'll compare you, they'll benchmark you against everyone that they have in their database, or if they purchase Medicare data, they can do that comparison as well. So there's a lot of resources out there to try to gain that benchmark view for your hospital. So you want to make sure you get that and then provide that when you're trying to present your initiative and move it forward. So when you start working with your hospital and you're working on your readmission, what you'll find is that everyone has an opinion. And what I like to use is the analogy of they want to throw 10 darts at a dartboard and hope one of them sticks. But at the end of the day, they never know which one is sticking, and they don't know what's actually working. And everyone thinks they know why patients are readmitting. So you'll have people that say, well, how hard can it be to keep patients out of the hospital for 30 days? It's harder than you think sometimes. Or it's just those 4 or 5 people. If we could stop those 4 or 5 people from readmitting every other week, then we wouldn't have a readmission problem, which may not necessarily be true in your hospital. It wasn't in ours. You'll get this research study says to do this hospital is doing this. I would get emails on a regular basis, hey, we should be doing this or we should be doing that. The key when you start looking at your readmission problem and start looking at potential solutions is look at the research, look at the data, and then decide what's going to work best for your hospital, and then stay the course. This does not happen overnight. It is not a quick flip switch. And so you really, and readmission data is slow because you're talking 30-day readmissions, and that is if you're gathering real-time data. So you have to remind people, especially when you're looking at Medicare data, because it's that 3-year average. So what happened 3 years ago, and 4 years ago, because it takes a while for them to report out the data, that is what's impacting some of your data right now. So when you make changes, your Medicare penalties or outcomes may not be affected for 3 years, depending on what your data looked like 3 years ago. So, but it is important to look at current research. So what's currently out there for reducing readmissions? There's Project Red, there's Boost, there's the Coleman model. So I started by looking at some of that stuff. Look at what does the research say that patients need to know? American College of Cardiology, Heart Failure Society, American Heart Association. What are those standards for what patients really need to know? And we're going to get more into that on the next presentation that we're having in another month. We're going to get into more detail about specifically what patients need to know and how to get them to understand. But then also look at how do patients in the hospital learn? What is their health literacy? How does the hospital environment affect their learning? What barriers are there to learning in healthcare? So, what does the research say on scheduling? You got to continually look at that because it's a fairly new area of healthcare, and there's a lot of models out there for what you should do, but you really have to weigh what is the cost effectiveness, what is the sustainability of this, And then at the end of the day, what is the research saying? Because some of the research is wide and varied on this topic. So the research is great, but you need to go to the source. You've got to go to the frontline people, talk to the people on the front line, interview, survey, interact. So what I did when we started working on this was I worked with patients, I talked to the staff. And when you talk to them, it's important to initially start by getting their perspective, because that allows them the opportunity to kind of talk through, and it allows you to learn where are they at? Where are they at with their line of thinking on this topic? But it also allows them to kind of vent about their feelings on this subject. And it allows you to respond to that. So I think these patients just like to come to the hospital. Well, I can tell you that's a very rare thing, that patients really want to be in the hospital. Now, it does happen, I'm not going to, but it is generally not the real cause that people are readmitting to your hospital. And then you'll get, my patients are not the problem. I've only had 1 or 2 patients readmit to the hospital. Well, first of all, 1 or 2 patients, if you've got a very small volume, can push your readmission over the national average. But what you have to go back with is, you know, you may have only had 1 or 2, but if you had 1 or 2 and Dr. So-and-so had 1 or 2 and Dr. So-and-so had 1 or 2, all of a sudden we're up to 6, 10, 12. And the reality is we have a readmission problem. So every patient matters. So that way you can kind of feedback with your key players and really try to get them to understand what is the true problem and get them bought into what you're trying to do. The other thing I hear a lot of is our patients are sicker, they have more socioeconomic problems, and you know, that is true in many places, but there are places that are very socioeconomically depressed. They have very sick patients, and they're managing to work through the readmission issues. So really it's about looking at your community. And the other thing you need to understand is the data is risk adjusted. So they do try to risk adjust that out. The other thing is that the 21st Century Cures Act is moving forward, and they are going to start looking at some of those socioeconomic issues. I think they're going to start with dually eligible patients. So your patients who are on Medicare and Medicaid, dually eligible, Medicare is looking for some sort of relief with that population. And I think they're accepting comments right now on that issue. So I think we will see more adjustment from Medicare, but it's not coming soon. And so, you know, you really need to start working on this problem now. But then once you get through that, then you start getting to the actual problem. And the way to do that is to ask the specific questions that you really want to know the answer to. How do you teach your patients about heart failure, self-management? You know, at Covenant, we had this big book that every patient got that nobody really looked at. Discharge papers, one-page educational tools, videos. They just tell them what to do. You'll be surprised at some of the answers that you get. You know, you talk to people about who's responsible for education. Okay, primarily everyone will answer nurses. In our organization, anyways, that was how it worked. But when you talk to nurses, they have a wider answer. You know, doctors are responsible, dietary is responsible, case management is responsible. But the problem is that the perception is that it is all on nursing. So you need to look at that, and if that's the perception in your hospital, you either need to give the nurses better tools to educate patients with, or a more efficient way to do it, or you need to start spreading the wealth around and getting buy-in from some of these other departments. So who schedules follow-up? That's another initiative. You know, a lot of people are working to schedule follow-up. If you talk to some people, they'll say the patient, some people say the PCT offices, some people say nurses, some people say case management, some people say unit coordinators. But if you go to one person and you say, and everybody says, oh, it's one unit, and everybody says, oh, it's the unit coordinator, and then you go to the unit coordinator and you say, oh, no, it's not my responsibility. It's an eye-opening experience. So whatever you decide to select, and there's a lot of different things, a lot of initiatives out there that can be selected to address the readmission population or the heart failure population for readmission. Whatever you select, you need to ask some of those key questions related to what it is, whether it's scheduling follow-up appointments, getting discharge summaries in the PCP's hands in a timely manner, all of those things, med reconciliation, you need to ask very specific questions of your frontline people. And then you talk to your patients, and boy, I'll tell you, patients say the darndest things, and you can kind of see here. I mean, I talk to patients that are, I have heart failure? I didn't know I had heart failure. I just don't drink a lot. Well, what's a lot? Well, I don't know. I just don't drink a lot, and the one, they gave me 30 pills, and I took it every day for 30 days, so I figured I was done. I didn't renew my prescription. I mean, I know if any of you have worked in this area for any period of time, you've seen some of these things. You've experienced it firsthand, but it helps to talk to patients and really, again, tease into exactly why did they come back. Now, there's a lot of tools out there. There's a Cleveland Clinic tool for interviewing patients, and it's fine, but typically when you go in there with a clipboard and you just start asking questions, you don't really get the responses. You really need to sit down with the patient and talk to them and talk through why did you come back. I mean, the one on the bottom, it says, I do not want to take a beta blocker. I don't want hospice. I just don't want to take a beta blocker. That really happens. I mean, and when patients don't want to do what we recommend for specific reasons in their life, we have to honor that. And it's not necessarily that they want to die or they want to keep coming back to the hospital. They just don't want to do what we're asking them to do. And so we need to honor that and talk about alternatives. So overall, though, when you're looking at data to try to determine what's going to work best for you, you really need to look at the right data. And I say look at the data on discharge, and that's where everybody goes first, is what happened on discharge, what were we doing before they left the hospital, and that's valid. You need to look at that. But you really need to focus on what's bringing the patient back. So what was their diagnosis on readmission? What was their chief complaint? When you look at diagnosis on readmission, I look at it three ways. I look at the patient's chief complaint when they hit the ER. What were they complaining of? I look at what was the admission diagnosis, and then I look at what was the final discharge diagnosis, because all three of those can give you very different pictures of what's going on with that patient. And when I started working with patients and I started looking at this, what I found out was, yes, patients do readmit for heart failure, but they also readmit for acute kidney injury, renal failure, and hypotension. We were spending so much time focusing on restricting fluids, restricting salt. We'd bring them in, we'd diurese the snot out of them, we'd send them home on a higher diuretic dose, and nobody would talk to them about the fact that they could get dehydrated. Nobody talked to them about the symptoms of dehydration. So that was a key piece in looking at how do we reduce readmissions. Look at when they're coming back. Is it within days, within weeks, within a month? For our patients, it was primarily in the first couple weeks. Where are they coming from? And you'll hear this in a lot of arenas. Oh, it's those patients that come back from the skilled facility because, it's the weekend and they just want to send them back. Well, number one, skilled facilities are starting to get dinged on readmissions as well. And number two, if you look at your data, that may not actually be the case. And in ours, it was not the case. Primarily, our patients were readmitting from home. And the other thing is the patients that you send to SNFs are typically sicker than the ones you send home. So that's another thing you have to take into account. If you do have an issue with readmissions from skilled facilities, what you want to do is look at which facilities are they coming back from. Are they taking the sicker patients? And if they are taking the sicker patients, how can you partner with them to improve the care in that facility? And then were they following the recommendations given to them at discharge? That's another key piece. And what I found when I started looking at this is, there was varying degrees of self-management techniques, but typically when they didn't do it right, it wasn't because they didn't want to. It's just they couldn't figure out how to make it work in their own environment. So what I did, and I'm not going to get into this in great detail, what I did was I created a toolkit to help patients understand their heart failure. It's an interactive tool. It's hands-on. It's very easy to share with families and caregivers so that they can help support it. It's education that can flow across the continuum of care. It addresses fluid overload, but it also addresses dehydration. So I was trying to get at everything that I saw as a barrier when I was doing my initial investigation. And, well, like I said, we'll talk a little more about that whole piece in the next presentation, but I want to kind of walk you through a little bit of the research study so that you get the data. So we did a pre-test intervention post-test, and then I did a 30-day post-test that was mailed to the patient afterwards. And what we did was we used Barb Riegel's Self-Care Heart Failure Index, and it really helped to kind of fine-tune maintenance. It evaluated maintenance management and confidence, so it really helped to determine where were the fall-throughs. So we did a pre-test and post-test and then 30-day post-test, and the secondary aim was to reduce 30-day readmission rate. So why didn't we just look at readmission rate if that was the goal? Well, what you will find, again, this is my 10 darts at a dartboard theory, you will have a lot of different initiatives in your hospital that are working to reduce readmissions. What you need to know is if the readmission rate actually reduces, why did it work? How did it work and why did it work? So that way you can further support what you're working on down the road. And I'll give you an example of how that works. So we admitted patients for a study that were in a primary working DRG of 291, 292, and 293, and we did have some exclusion criteria. We had 50 patients. We ended up with 41 patients in the study, and they completed all 3 surveys, which was the return rate of 93%. And so we got great feedback, and this is some of the feedback we got. It was awesome. And so it's very easy when you start getting good feedback from patients when you're doing this type of work to say, oh, but our patients love us. Oh, they love what we're doing. They know it's working. We know it's working because they're telling us it's working. And that's great, except that is not going to move your initiative forward. You need to have the data that supports exactly what is going on with your program, exactly how is this improving care at your hospital. You've got to have the data to back that up. So every time I start an initiative at the hospital, every time I would work on something new, I always made sure that there was a way to collect data. I had a great Epic builder. We were on Epic. I had a great data analyst, and the 3 of us would sit down in a room and we would work out, okay, we're going to document it this way, and if we document it this way, it can be abstracted so that we can get data down the road. So initially, everything that I did was manual abstraction, but now it's set up so that they can know, the hospital can know real time. Every patient that gets a toolkit, what's the readmission rate? Every patient that gets a transition coach, what's the readmission rate? Readmission rates by unit. So all of that is set up through very careful planning and making sure that when you put something into place, there's a template in your documentation or there's a system within your hospital to, down the road, collect data. And there's data points that we're not even, I'm sure, since I left the hospital, I don't know what's been going on, but I'm sure we're not even collecting data on some of the data points that we potentially could be. But again, just to kind of give you an idea, this is how you need to start setting things up so that down the road you can further support whether or not what you're doing is working and how it's working. So when you look at Barb Riegel's Heart Failure Self-Care Index, there's different levels of engagement in heart failure self-care to influence specific clinical outcomes. So greater than 70 mean was equivalent to self-care adequacy. 50th percentile marked reduction in odds of having episodes of hemodynamic congestion and risk of death or hospitalization. 75th percentile was direct inpatient cost savings seen. So this was the data, and you can see the pre-test, everyone was below 60. The post-test, everyone was above 70. And in the 30-day post-test, everyone maintained. There was a slight drop in the maintenance, but there was an increase in the confidence with heart failure self-care. So that was pretty good data, and these are the hard numbers that kind of show you exactly where the numbers fell in. But how did we do with readmissions? Well, there were 44 patients in the study, 4 readmitted, so we had a readmission rate of 9%. That, along with the other data, convinced the hospital that we needed to do this further. So they purchased 100 more kits, and I wanted to prove that an RN could use this just as easily as a nurse practitioner. And I had a RN transition coach that I was working with. Her name's Bonnie Hartwick. If she's on the call, I give you a shout out, Bonnie. She's an awesome person. So she partnered with me, and she started using the kits as well. And in January and February of that year, we had 37 patients that successfully stayed out of the hospital for 30 days, 4 readmitted for a readmission rate of 9.8%. So that proved that an RN and a nurse practitioner could both effectively use the kit. However, we were still missing something. We were missing the comparison data. I did not have the resources to do a double-blind study, all that stuff. So what I did was I looked at 4 months of data, and I pulled 255 heart failure patients over 4 months. That was how many patients we had discharged over a 4-month period. It was January to April, and this was where they came from, most of them from a non-healthcare facility. And so then what I did was I looked at a lot of different variables, but there was 2 things that I really wanted to look at. At that time, we were trying to localize all of our heart failure patients to 1 unit so that we could better hone in their care. So I wanted to see, number 1, how well were we doing that, and number 2, whether or not it was effective. And then the other thing I wanted to know is, did the kit actually work? And so this was kind of a leap of faith. And so the patients who ended up on PCCU, which was our heart failure unit, 57% of them ended up on the heart failure unit. The readmission rate on PCCU was 19.2%. 43% ended up on other units in the hospital, and the readmission rate was 25.7%. Now, if they were in the hospital and got a toolkit, the readmission rate was 13.7%. When they were on other units and they got a toolkit, the readmission rate was 17.2%. So I thought, well, that looks pretty good. So this is the hard numbers that went with that. So then I looked at, what if they got no intervention? What if they got just a transition coach with no toolkit? And what if they got a toolkit with a coach? What was the difference there? So 23.5% got no intervention with a readmission rate of 33.3%. Transition coach only was 45.1%, and the readmission rate was 23.5%. If they got a coach and a kit, that was 31.4% of the patients, and the readmission rate was 12.5%. So that was convincing enough for the hospital to purchase 1,000 more kits. We now have a consult for transition coaches in Epic. We are now using them on all AMI, CHF, and CABG patients with an ejection fraction of less than 50%. And yes, the nurses enter the EF as a hard data point so that we get a list every day of which patients are in the hospital that have an EF of less than 50%. So again, it's about making sure you get the data put in so that you can abstract it for meaningful use. And each patient who gets a kit gets a call within 72 hours of discharge. And then we also have a late risk score built into our system. We were initially manually calculating that on every patient to determine how intense our follow-up needed to be. The low risk got 1 call, and the higher risk got more intensive calls, usually weekly for 4 weeks. But now we have that built right into our Epic system, and so that score comes up on your patient list every day. So where are we at now? Well, 2016, the national rate is 21.9%, and hospital that I was working at, it is now 22.5%. So we've had some improvement. Here's some other data. Again, important to look at more than one data source. So what I did was we pulled HCAP scores for the 2 units that most of our patients are on, and we compared the unit score to the unit score if a patient had a transition coach. So you can see the scores with the coach are blue, and these are the questions that are relative to care transitions. There's 6 questions that are relative to care transitions on the HCAP. And so you can see the coach's scores are much higher than the scores for the statewide average, which is your line above. And they're also higher than if they were on the unit with no coach. In some questions more than others. So the coaches are the blue, and the patients with no coach are the red. Pardon me. So then this is the other unit. PCCU is our other unit where a lot of our open heart patients and our AMI patients are localized as well. And you can see again, the coach HCAP scores are higher than the patients who were on the same unit with no coach, who were discharged with no coach. And then, of course, doing reasonably well in comparison to state. Not as good, but reasonably well. And then this is from Readmetrics, from Arbormetrics. And what this looks at is a readmission for same DRG. So the green line is everyone in the database, and the blue line is the hospital where we did all of this work. And so you can see where in 2013, when we started this initiative, we were above the average in their database. And you can see patients readmitting for heart failure has significantly dropped over the last couple of years. So that was a pretty positive thing. So that kind of shows you and gives you a little idea of what we went through and how we use data to move our program forward. I do want to spend a little bit of time talking about one of the tools that we used with our AMI population to look at readmissions, which was a common cause analysis, and just kind of walk you a little bit through what we did with that. So a common cause analysis aggregates acts and causes from multiple events to identify a common cause. So the same thing is happening over and over and over again over time. Where if you're looking at a root cause analysis, that's a single event. It's driven by a single event. Common cause is more of a time or a trend. It allows an organization to determine a broader look at system vulnerabilities versus looking at one event. And it's usually less resource intensive than a root cause analysis. So this is just a little bit of a chart from Clapper and Cray. It's kind of a nice way to summarize the difference between common cause and root cause analysis. So root cause, it's a single case. Common cause, it's many cases. Root cause is more event-directed, a single event, whereas common cause is more time or trending directed. And root cause looks at efficient for diagnosis process, protocol, and technology causes, whereas a common cause analysis is more efficient for diagnosing people, leadership, and environment of care causes. Root cause investigates cause and effect relationships directly. Common cause analysis is more of an inference of cause and effect relationships using existing analysis. It's more of a qualitative type approach. So these are some opportunities where you could use a common cause analysis. Any of these hacks that you're looking at, sepsis, infection rate, unplanned extubations, catheter-associated infections, but certainly readmissions is a great, it's a great tool to look at that. So this is just a little example. This is all fake data in here, by the way. You can see, like, it's using baseball players from the Detroit Tigers, so this is not real data. So what you need to do is gather your data, identify as many variables in the process as you can. So this one looked at, is kind of looking at infections, and it's looking at, okay, what organism was it? What was the date of the culture? Did they have a central line? Those types of things. So you're looking at all of the different variables that might affect that process. And so then you put it all together, and then you start thinking about what information do you need? What are some of the trends? What are some of the patterns? So I want to give you a little bit of a case study as to what we did and how we used this at the hospital. And so you can see, and I know you can't really make out this chart very well, but I kind of want to just give you a little bit of an overview. So what we did with this is we looked at 14 patients who readmitted after being discharged with an AMI diagnosis. And I pulled together, based on my experience and feedback from a lot of different people in the organization, we talked about, I put in, well, we put in their age, their gender, the admit date, the discharge date. But then I looked at what was the discharge day of the week? What was the time they were discharged? What unit were they discharged from? How many days after their discharge did they readmit? Was their discharge nurse experienced or were they new? And I define new as less than 6 months in practice. And so I looked at that. I looked at case management. Who was working with them on case management? We had a lot of people filling in for case management. So was it the unit case manager or was it somebody that was floating in? What was the discharge recommendation of the case manager, and did the patient actually follow that discharge recommendation? The discharging physician service, was it cardiology, was it hospital medicine, was it primary doctors in the community? I looked at what was their ejection fraction, what was their LACE score. We looked at, are they still living or not? Because as I started pulling up patients, when I was working with heart failure patients, I noticed this. We get a little red flag every time a patient is currently deceased. I was getting a lot of red flags. And so I thought, well, this is less than 6 months out. Did we think about palliative or hospice, or was that even considered? So I looked at it. Well, are they still living? Did a transition coach follow them? Was their follow-up appointment scheduled? What day did they readmit? What time of day did they readmit? So all of that, the timing is compared to when they were discharged. Was it within days? Was it within weeks? All of those types of variables. So I put that all together, and I took this spreadsheet, and I made it a giant piece of paper that would spread across 2 tables. And we brought together a group of people from all through the spectrum. We had community family practice. We had nurses, hospital medicine, physicians, emergency medicine physicians. We had nursing from the nursing unit. We had cardiology. We had some residents, nurse managers, nursing education, utilization review, case management. All of those people, we brought them around the table. I rolled out 2 of these giant sheets, and I said, I want you to look at this data and tell me what you see. Tell me what you think are common areas or themes that you think we should look at with regards to readmission. So after the first meeting, this was the common theme, some of the common themes. There were some other ones, but these were some of the common themes that we thought needed to be reviewed further. Observation versus readmission. I did look at what was the length of stay on the readmission. And what we found was many of the patients on readmission had a length of stay of less than or equal to 2 days, which begs the question of, could they have been cared for under observation? The problem is what we found out is that our physicians are getting mixed messages, because we've got utilization management saying, oh, you need to put these patients in and admit them, and then you've got people in transitions of care saying, oh, do you think maybe we can put this patient on OBS because, if they're not admitted, then they're not a readmission. So it puts the physician in a difficult position. So that was kind of an enlightening thing for us to go through, and it was key that we had some of those physicians sitting around the table. And then we looked at palliative care approach. We did have a large amount of patients from that data set that were currently deceased. And so the question was, would the patients have benefited from palliative care? And, at the time we had no palliative care program. One of the questions was, did these patients have eyes on the patient in the home? Would they have benefited from home health care? And then also the time of discharge and the time of readmission, because what we noticed was many of the readmission days and times were times when the physician's offices were closed, would have normally been closed. So what resource do we have out there in the community that's going to help these people if they're needing help rather than just to come back to the ER and then end up readmitted? Follow-up appointments, They were scheduled on most of these patients, and this is not correct in here. We did not know whether or not they attended at this point. But we did notice that many of the chief complaints on readmission were cardiac related. So that begs the question of, okay, great, they get a PCP appointment. Do they need a cardiology appointment sooner? And what type of assistance do the patients have at discharge? That was one of the questions. We really don't know. So they asked if we could do a larger population. So I broadened the population to 33 AMI patients. Now, understand, I know these volumes are low, but this is very labor intensive. This is manually going in and looking at these patients. So after we looked at the 33 patients, we further honed our key areas that we wanted to focus on. And one was observation versus admission. We decided there needed to be a high-level conversation about cost-benefit and standardizing approach to this question. And so that was lifted up to leadership to kind of look at how do we approach that. And then the following areas of concern were identified, but they really felt that we needed additional data from a comparison population. So we looked at extra eyes on patient in the home, the need for palliative care, timing of discharge and timing of readmission, is there a difference in day of the week, and follow-up appointments scheduled, but did they attend? So we pulled 33 patients, we randomly pulled 33 AMI patients who did not readmit to the hospital. So now we have a total of 66 patients, and we went back and looked at all the data, and then we went back to the group. So we did notice some differences in the common cause themes for the patients who attended follow-up appointments were less likely to readmit. All 33 of the non-readmitted patients discharged home ended up follow-up appointment and attended their appointment with their PCP. The patients who readmitted had an appointment attendance rate of 44%. So the attendance rate was only 44% for patients who readmitted, 100% for patients who did not. And what we also discovered is we pulled the LACE score on all these patients as well. That was another thing, is does the risk assessment really work? We had mean, median, and mode for the LACE score were all higher in the readmitted patients. So we felt that that was a good predictive indicator. So that was when we moved forward with building the LACE tool into EPIC, because we felt that that was a valuable tool to really help determine the level of services that we needed for each of our patients. The other thing with the palliative care we did do, on a side note, I looked into a couple of the patients who were deceased and looked at how frequently did they readmit, did they have different providers every time they readmitted to the hospital. And in fact, there really was no consistency with providers when those patients readmitted. So that was another area, and the hospital has moved forward with a palliative care program based on that data. That data was taken to an executive team meeting, and this data plus the additional data that I pulled on the readmitted patients, and it did convince them that we really needed to look at a palliative care program. So that was something that has happened. So next up, common cause themes were identified. So the common causes have been compared and contrasted between comparison groups to validate. And so then the hospital started working on action plans to move forward with initiatives. So that kind of goes through, I know it was like a lot of information to try to cram into a very short session, but it does go through, gives you a little sense of, how we use data to move our program forward, how we use common cause analysis. And I know we only have a few minutes left, but I'm more than happy to answer any questions that people might have. And I also did let them know that they could provide my contact information in case you guys have further questions after the session's over.
Okay. Thanks so much. So, operator, can you open the lines for questions and answers?
Absolutely. Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Our first question comes from Kathy Heifer. You may now begin.
I was wondering if you could tell us how we would access the toolkit.
Well, I had to be careful. I'm not very good at self-promotion, and I had to be careful, but if you email me, they're going to provide you my email. It's kbushselfcare@gmail.com. And if you email me, I certainly would be more than happy to give you the information. I also have a website. It's called selfcaresolutions.net. So I'm more than happy to work with you and give you more information on the toolkits and what's in them and that type of thing.
Okay, our next question comes from Ms. Patel. You may now begin.
Yes. How does Medicare and Medicaid check the heart condition?
I'm sorry, I didn't understand
This is a
the
very
question.
basic question. How does Medicare and Medicaid check heart health condition?
Oh, how does Medicare and Medicaid count health conditions?
Yeah. What's the government approach to checking its citizens' heart condition?
Well, they don't. So Medicare and Medicaid are payer sources. So when the patient is discharged from the hospital, they're discharged under diagnosis code. And so if there's a diagnosis code attached to that particular episode of care, and it falls under the DRG that is heart failure or AMI, then that's how they track. So it's if you're discharged. Now, if you're looking at bundled payments, like for the AMI population, if they're discharged under an AMI DRG, and it's in the DX1 or DX2 position, then those are patients that'll fall into your bundle. Does that answer your question?
Yeah. It's broad.
Okay.
Oh.
Okay, our next question comes from June Schofield. You may now begin.
I was going to ask about the toolkit as well, so I'll just wait for your email at the end.
Okay, great.
And our next question comes from Julie. You may now begin.
Hi there. I was just wondering, when you had made a comment on your first few slides about the hospital readmission reduction program, and it's now impacting the skilled facilities. When actually does it start impacting them, and what is the look-back period?
I'm not as familiar with the regulations for skilled facilities. I believe it started, and if somebody's out there that knows the answer to this and wants to email me after, I'll get you the answer. But I believe it started in January 2017, and I believe the look-back period is 3 years, just like it is for the hospital. But I am not absolutely certain on that. I'm sorry, I'm not as versed in the skilled facility realm as I am in the hospital realm.
Okay, thank you.
Yeah.
Okay. Ellie, there's no other questions in queue.
All right, we have one question in the chat. I hope I can give this to you correctly. It says, out of the 17 patients that attended a primary care physician appointment, what was the time frame for follow-up appointments? Was it in 7 days of discharge or some other length of stay?
Our hospital standard is 7 days. It's within a week of discharge. That's our hospital standard, and that would have been what I would have counted, was within a week of discharge.
Okay, great, thanks.
So, yeah.
Okay. I don't see any other questions in chat at this time. Operator, are there any other questions, phone calls on queue?
Yes, we do have another question from Mr. Patel again. You may now begin.
Yes. In reference to what you presented on, does Medicare Part D have specific prescriptions with what you're describing here on improving the heart failure self-care and reducing readmissions? Are there specific Medicare Part D paid prescriptions?
Yeah, Medicare Part D is it doesn't really relate to readmissions other than to, like you said, there are certain medications that they cover under different plans within Medicare Part D. It kind of depends on what plan the patient is on. typically the newer medications are not covered under Part D, but your standard medications, the generic forms of your standard medications would be covered. So your ACE inhibitors, your beta blockers, your diuretics, typically they're not going to cover the newer medications unless something has recently changed. I don't believe many of the programs were covering Entresto, which is one of the newer ones that's out. But as far as covering medications that are acceptable for use in heart failure patients, you can usually find one within each drug class that Medicare will cover with a minimum copay. And truthfully, there's typically a Walmart, I'm not trying to promote any specific company here, but typically there's a $4 list from one of the chains that does cover each drug class. And then if your patient's having trouble with that particular drug, then switching might require some prior authorization paperwork. But as far as readmissions go, Medicare Part D doesn't really have a lot to do with the readmission penalties. Those are penalties specifically to hospitals.
Thank you.
Yep.
Okay, our next question comes from Kathy Ponder. You may now begin.
Hello, Karen. It's Kathy. How are you doing?
I'm doing good, Kathy. How are you?
Good. Thank you for the excellent presentation. And I know we've been communicating with our plans to use your heart failure kit. Also, will your slides be available for us to review? We have a heart failure committee that I sit on.
I believe they will be. That's going to be a question for the Quality Improvement Network, but I thought that they said there was going to be a way that they're going to be available, but I think it's not going to be for a week or so.
Okay.
They can jump in and correct me at the end there.
You're right, Karen. We do have a link in the chat that you can get from our website that you can download the slides from.
Okay. Yeah, because I think it will be helpful because we're going to start to dive into some readmission data or information and looking at root cause, but it was very helpful. So thank you.
Yeah, no problem. And like I said, they're going to provide my email at the end here. So if anybody is starting to dive into this and they're not sure, feel free to reach out to me. I'm more than happy to try to help out and guide you if I can. Okay?
Thank you.
Thanks. I think we have time for maybe one more question from the chat here. It says, did you have an EPIC expert help develop the reports and the scope of the reports is significant? I think we need to build it. Do you know did you have some?
Yeah, so I had an EPIC builder. Her name was Sherry. I had, at the same time, I had a data person whose name was Michael over at the hospital. And like I said, the three of us would get our heads together and we would look at the process we were trying to tackle. And I would work with Sherry and we would build into EPIC the flow sheet, and we made it very so that it would be easily abstracted by the data person. So the three of us would get together, and Sherry, who is an EPIC person, would build the flow sheets, which I think if they build them in EPIC, they're available to anyone. We have a transition coach flow sheet, and it just clicks right through answers to questions. I also had a trigger system built so that if a patient did not have a follow-up appointment when they left the hospital, and we did a follow-up call, and in the follow-up call, if they indicated that there was no follow-up appointment, it automatically went to the next question, which was, would you like a transition coach to help you make that call or make that appointment? And if they said yes, it auto-populated a list to the coaches the next day to follow up with that patient and make sure that their appointment got scheduled. So those types of linkages require having an EPIC person and a data person and somebody that understands what you want to do with the process, sitting around a table and saying, okay, if we build it like this, then, you know, the coach that's going through or the nurse that's going through can click this and this and this, and we can pull it into this. So, yeah, the answer to that question was I had an Epic builder and I had a data analyst who were really engaged in the whole process. And so we were able to build some things that were very impacting and are continuing to be used at the hospital now.
Thank you so much, Karen. Thanks. At this point, we have reached the top of the hour, so this was just a very interesting and informative webinar, and I think this is one of the highest attended webinars we've had, as well as some of the most interesting questions, so I really appreciate it. And thank you for your
hopefully everyone will get on the next one.
I hope so.
Come on.
Oh, so thank you so much. We really appreciate it. I just have a few more housekeeping things. Just wanted to reiterate that we thank you for joining us today for the Improve Heart Failure, Self-Care, and Reduce Readmissions Using Data to Understand the Problem. As a reminder, the slides will be available on our website, the Lake Superior QIN YouTube page, within the next week. Now, if you are interested in receiving CEs for this presentation, you will need to fill out the survey that will be posted shortly, and then you will be sent a certificate of attendance after that to your email. Be sure to join us for our upcoming webinar, part 3 of our heart failure webinar series called Standardizing Heart Failure Education and Engaging Your Patients in the Standard. It will be held on August 23rd from 11 to 12 p.m. Central Time and 12 noon to 1 p.m. Eastern Time. Thank you so much, and I want to thank Karen Bush again for a wonderful presentation, and I hope everyone enjoys the rest of their afternoon.
Thank you, everyone, for joining. You may now disconnect and have a great day.